Hello, everyone. Thank you so much for joining me today on Nurses Out Loud Q&A. This is our new format that we are promoting. So please send in your questions to us. That is nurses@americaoutloud.com. And we will answer them on air. And today with me, I have Nurse Kimberly, who is your Wednesday host, and our nurse co-host, our nurse guest co-host, Nurse Nicole. That's another thing we want to offer you. I know that there are many of you guys out there that are fighting the good fight alongside of us, and we would love to have you on as a special guest and opine on, the different topics that we talk about. So please send us a message, nurses@America Out Loud, and just let us know what you've done, what you're doing, and why you would like to be a guest co-host on our show. So welcome, ladies. Thank you for joining me today.
Thank you.
Yeah.
I'm excited. Nicole's here. I'm excited. We had such a great conversation last week.
It really did. It was awesome.
Do you remember the title of the show, Kimberly?
Of the show that we did?
Yeah.
They changed it. So no, I
No.
don't. I had one title, but I think that the editors changed it. So, but hold on.
Like informed consent, something about informed
Yeah,
consent.
something about fighting for informed consent from the bedside, I believe.
Awesome. Well, we will put that in the show notes on today's show, so you can listen to that interview. Nicole and I did an interview just now about what it's like being in the hospital, and also all the chest pains that we are seeing come in. Nurse Nicole works in a chest pain center where she gets all of the documents from the people that leave the ER, essentially, or the hospital, and they get worked up so she can really do deep dives into their charts. And she's noticing a huge correlation between vaccination, comorbidities, and adverse outcomes like heart attacks. So that will also be in our show notes as well. So yeah, matter of fact, guys, just right now, whatever you're listening to us on, put it so that you get access to the shows all the time, right? If you're listening to us on your podcast app, then make sure that you have our shows saved, and that you are getting notified of new shows that are coming out, because we are speaking on air 5 days a week, on live on iHeartRadio or on our America Out Loud Talk Radio app that you can download at 10 a.m. Eastern Standard Time, with an encore at 11 p.m. Eastern Standard. And as always, all of our shows go to podcast a day or two later. So make sure you are saving, sharing, liking, reviewing our shows. We absolutely love that. And so do the algorithms in these tech places. So the more that you guys are doing that, and the more people that are viewing it, obviously the more education that is going out there. And that is why we are doing this. We're not doing this to hear our own voices and our opinions. We're doing this to educate the world. Essentially, we want everyone to know, like, we are ethical nurses, and we stand by our oath, and believe in autonomy and informed consent and all of the ethical principles of nursing. So make sure you are promoting us and sharing our shows. So thank you for that. So let's just get started. I received a message from someone who is anonymous, which that is absolutely fine. They said, "Hello, RNs. I'm planning on quitting my new grad RN job at 5 months to do solo traveling for at least 6 months." And I had to ask for clarification. So this is a new nurse that has been working for 5 months. And she wants to leave to go travel the world, having fun, for at least 6 months. While I know this isn't the best thing to do financially, I would like to hear your insight if this would impact my chances of finding a job as an RN after I finish my solo traveling. I'm open to all of your wisdom and advice. Kimberly, you want to give your
I
opinion?
do.
Yeah.
I do. I do. You just see me because we're on camera. We can see each other. I think she sees me like jumping out of my chair over here. Um, I can completely understand that you want to travel and that you probably are disillusioned with the system and the way that it is. But I do not recommend travel nursing at 5 months post graduation. That is not safe.
No,
That is,
no, she doesn't want to travel nurse. She wants to
oh,
travel the world, have
oh, okay. I feel so much better now. Okay. Sorry. I was like, please don't do that. Don't do that because that is not safe. No,
right.
no, no.
Yeah, I
Okay.
actually don't even think that a travel company would take her if she doesn't have at least a year.
Well, they will now.
Yeah,
Yeah, I
true.
think that they
True,
will
true.
now. Oh, so do I think that if she took some time off to travel the world, do I think it would affect her chances of getting a job later?
Yeah, she's been a nurse for 5 months as a new grad,
Mhm.
and she wants to leave for at least 6 months and then come back and be a nurse.
No, I don't think it'll affect your chances if you have a heartbeat and a pulse. They're going to take you. I mean, I hate to say it like that, but it's true. I mean, honestly, I mean, with the shortages being what they are, I mean, you can pretty much, I mean, they'd almost take me.
They took me.
They'd almost hire me. I'd really almost like to like test that theory and go apply for a job at the hospital I left and see if they would take me back. Just, interesting. I mean, I'd never go, but it would be interesting to see.
Maybe you should do
No, yeah,
that. You should just do it for the heck of it.
I should. Then I'll record an episode on it. I think that would be fun. Yeah, no, I think, no, my opinion, no, I don't think you'll have an issue. Go enjoy, go travel, take a break. Keep learning though, keep reading, keep
Nurse
studying.
Nicole.
I mean, again, just to kind of piggyback off that, we do have such shortages that I don't believe getting a job is going to be difficult. However, sometimes with that little of experience and then kind of coming out, medicine is changing a lot and we do different protocols and different things. So depending on where you may look to get a job, it may be a little difficult for you to get acclimated because again, there's a lot of changes, but there are currently, I think the last time I looked, over 1 million job openings in the United States for nurses. So they are not few and far between, but again, to be selective in what you may want to do could also impact, where you go. So
Yeah.
yeah.
Plus, at 5 months post grad, I mean, it took me literally years after graduating, so I
Yeah.
didn't feel like a baby nurse, right? But I actually felt like, oh my God, like I can actually do this on my own. Because when you come out of nursing school, you don't know what you don't know until you get to the bedside.
Right.
And so, you're probably just starting to get your momentum and starting. So for I mean I was if it's the only consideration you have is will you get a job, yes, you'll probably very likely get a job, but I don't think it would be the smartest thing to leave and then come back when you're just kind of getting acclimated to nursing and to being at the bedside. It's probably a better idea for you in the long term, and this is not finding a job, but just you for your own career and your own knowledge and your skill set. It would probably be better to continue on right now. I don't want to give
Yeah,
you
I
bad
mean,
advice.
my
Go
opinion,
travel.
do what?
I was like, I feel like I was giving bad advice. I'm like, yeah, go travel, screw it.
We
But I
wish
mean, when
we
you
could
really
be
think about
you.
it, it's not a good idea because you know how long it takes you to get acclimated, especially to a new unit, to a specialty, as Nicole said. So yeah, I mean, it's not like, you're a seasoned nurse. If you were a seasoned veteran nurse, I would be like, yeah, go take some time off, whatever, come back. But yeah, you want to kind of continue on and get acclimated to your environment and to nursing and as a whole.
Right.
Yeah, I think my opinion on it would be more immediately I'm questioning you really wanting to be a nurse, right? I know that when I graduated as a new grad, I mean, I loved it.
Yeah,
I loved it so much. And I was just so happy to go into work on my 3 shifts a week and spend that time, off. I think if you're wanting my wisdom on that, I would suggest doing that. Try to group your days together and then have a big chunk off where you can travel for a week at a time, 10 days at a time, right? And then you come back and work your 3 shifts in a row or 6 shifts in a row, and then go out and travel. But I am a huge proponent of traveling and seeing the world. And I know that if you're a new grad right now in 2024, then you went through school during COVID, right? And you don't really have a lot of insight as to what that means, like patient care, right? Bedside care, the culture on the units, those kinds of things. So I agree with Kimberly in saying that I would try to hold out for at least a year, another 6 months, right? And unless you're a new grad and you're a month in and you're already planning what you're doing at month 5, maybe nursing isn't for you. And that's fine. That's totally fine. Maybe you want to reevaluate and look at what your options are, because you don't have to be a nurse at the bedside. I mean, you could work with Kimberly at Remnant Nursing, do an advocacy. Yeah. So I would suggest going to remnantnursing.org and checking out all of the different options, because you can work remotely. And have your own business. You can,
and you'll be trained in functional medicine. So we'll indoctrinate you to kind of what you've learned in nursing school. I mean, in nursing school, you have to take what you can get from it. But a lot of it is, we learn a lot of valuable skills, and we learn a lot of valuable things in nursing school, but a lot of it is a lie. So we have to, I mean, it just is, it is what it is. A lot of it is a lie. And we have to start looking at people holistically.
Yeah. Yeah. So I think that answers your question. Did you want to add anything to that, Nurse Nicole?
No, I think it's good. Like I said, unless it's something for like mental health reasons or something like that. But even then, if you're a few months in and mental health is now coming up as a concern where you need to take a break to travel, then like you said, we might need to reevaluate the right area as a nurse, which there is no shame in that at all, because it is very different. But again, just depending on the reasoning, could vary kind of what the opinion is. But just to evaluate where you are and to make sure, is this the right fit, and to know that if it isn't, that's okay too. There's plenty of areas, like you said, you could go into and have options.
And I second what you said, Jodi, taking that grouping your days together. And that's the beautiful thing about nursing, is that you can work your 3 shifts, have 4, or that you can set it up to where you're able to take, 7, 8, 9, 10 days off at a time. So it's a beautiful thing. That's one of my favorite parts of being a nurse when I was at the bedside. So I think that was great advice, Jodi.
Yeah, mine too. I that's what I did. And if I wanted to, and then don't forget, you're accruing PTO during that. So, as the weeks go by, you can maybe take a 2-week vacation, and, and then you have sick days. Don't be afraid to use them. They're yours. I always tell people too, sick days doesn't mean that you're running to the bathroom every 5 seconds, right?
Mental health day, and you need one as a nurse.
Absolutely. So, throw in a couple sick days in there and take another trip. Just don't post it on social media and you'll be fine.
Yeah. They're going to guilt you no matter what anyway for taking a day off. It doesn't matter. They'll like you all day long.
You'll have to ignore that.
Yeah. Yeah.
All right. Sure. So our next question is from Lisa. And Lisa says, what are y'all's thoughts on nurses protesting for safe staffing and blocking the buses of travel nurses that are getting bussed in Hawaii? Are you familiar with what's going on in Hawaii?
So I was not familiar, just other than that like brief little rundown that I got right when we started the show. But I have a kind of unpopular opinion. I have, that's nothing new, right? Nurse Kimberly has an unpopular opinion. So if you recall, like I think it was 2 years ago, they had the Million Nurse March on, I think it was in DC.
Yeah.
And which, listen, I get it. I get it. We've been begging for change in this broken system for decades. The system has been broken long before COVID. COVID just kind of brought shed more light on the brokenness of the system, but it's been like this for decades, probably centuries. Look at Florence Nightingale and her quotes from on in Notes on Nursing, where she talked about bad architectural and bad administrative practices made it often difficult to nurse. And it's true. So it's been true for a long time. And so while I get it, where we were protesting for safer staffing, more pay. It's not that I don't think we deserve more pay or that we need safe staffing. Absolutely, I do. It's just that these are problems that have plagued our profession for decades and longer. And we keep asking for change. It's not coming. It's not coming. How long are we going to continue to do that? That's why, for me personally, that's why I started Nurse Freedom Network. That's why I started Remnant Nursing, because I was tired of begging for change that wasn't coming. So I had an unpopular opinion, and I didn't participate in that Million Nurse March. And the reason why is because we were not allowed to speak about vaccine mandates, which to me, if we're not talking about bodily autonomy, like what else matters?
Yeah.
Right.
What else matters if we can't talk about our own bodily autonomy? So for those reasons, I chose not to participate and I took a very unpopular position, and I upset many of my followers that were supporting me. They could not understand why I would break from, the nurses. But again, I think I don't like the way that they're pitting nurses against one another. That's by design, in my opinion. And I don't like it. We're all nurses at the end of the day, and we should be supporting one another, whether we're a travel nurse or a staff. And I totally get it. I mean, travel nurses are getting paid 10 times what we got as staff, but we all have the opportunity to travel if that's what we wanted to do. I didn't want to do that. I didn't want to leave because my community, I felt like my community needed me at that point, because everybody was leaving the bedside to travel for 10,000 a week. Well, who's going to take care of our family, our neighbors, and those of the people in our community? So I stayed behind, but I had the option. So you can't guilt anybody, for taking that. I don't blame a single one of them that left to do travel nursing. I do hate that they didn't speak up though about what was going on, because the 10,000 a week, in my opinion, is blood money, hush money.
Yep.
That's my
Yeah.
opinion.
Nurse Nicole, you were a traveler, right?
Yes, ma'am. I traveled from 2022 to 2023. So kind of more so towards the end of it, if you will. I personally traveled just to get away from the politics of the hospital that I was at, more so because of what I was seeing on the unit that I was working on, and the fact that I wasn't vaccinated for the COVID-19 vaccine, how I was being treated, and how it wasn't getting any better, and the culture was really toxic. So to kind of go maybe a little bit of a different perspective, when everybody might not know that not every hospital allows, if you will, nurses to strike. Usually you have to have a union or something in place that allows nurses to do that without necessarily losing their job. There's other ways to maybe stand out, but like Kimberly said, a lot of this is repetitive in nature. It's kind of almost seems purposeful. There's a reason why almost every single state in the United States does not have safe staffing laws. People will say it's because of like emergencies or, disasters, and, what would we do? And, the big takeaway is that our culture has consistently declined in healthcare. And for the most part, nurses will strike because they feel like they're in unsafe situations, and they're being put in, not being paid for all the work they're doing with taking on. I always say that the goal is to, do more with less. And so a lot of times it boils down to, their compensation, their safety, making sure that management is held accountable. And so to go along with what's happening in Hawaii, these types of tactics have been happening for as long as I've been a nurse, almost 2 decades. And what I don't like, whether I was a traveler or not, a lot of the nurses that strike have very strong opinions about what they call these travel nurses as scabs. This is a term that they use. It's supposed to be offensive. And they call them scabs, and they get really upset. And I understand why. The hospital, it doesn't make sense. They can't pay you a raise or fix your staffing, but they can pay, $10,000 a week. It's a very short amount of time that this happens. But also, too, to remember that the violence against each other, and the fact that there are actual healthcare professionals striking for a good cause, and then turn around and, block buses and threaten violence against nurses who, are just coming to do a job. Now, whether they choose to do it for the money or not, the problem is that there's a patient laying in that bed that needs some care of them. And whether it's you striking or having the option to strike, these nurses are being brought in so you can, they're being given this opportunity, whether we like it or not. And at the end of the day, these patients need to be cared for. And so my opinion is that it is what it is. It's one of the parts that come with it. If you want to strike, you have to have someone else brought in so that the patients can be taken care of, because that is unacceptable, unethical. And, the fact that you would try to say that you're doing something for good and then turn around and try to harm your own and, name call and threaten and everything else, it makes you no better, So to me, it's a very touchy subject. I don't think it's appropriate or it should be allowed. And so, we keep seeing it. And again, like Kim said, I think it's all by design to really kind of segregate and separate, and again, those same people don't realize the hospitals are not going to do things long term. If you want to make real change, you have to get this kind of volume together and maybe go to your legislation, go to your state, try to make change at a state level, because these hospitals are going to get away with it until they're forced by law to change, which most are not willing to do. So, that's really my opinion on that.
Yeah, I think we need to break it down a little bit, right? So let's talk about this in terms of topics. One, these nurses are striking for a better patient to nurse ratio, meaning, and I want to let the listeners know, for example, on a typical med-surg unit, that is where people are placed in the hospital for everything other than cardiac related or critical care. Okay. That's where all of your post-ops go. That's where all your diabetics go. That's where all your wound care goes. That's where all of your psych patients go. The med-surg is pretty much a dumping ground for everything that's not critical and that does not need cardiac monitoring, meaning like it's not a heart issue and we need to keep you on a monitor looking at your rhythm. In those situations, good patient to nurse ratios are 1-4 on day shift and 1-6 on night shift. These nurses, what were you working? What were your ratios as a traveler, Nurse Nicole, and what area were you in?
Depends on the specialty. So if I was on a step down unit, sometimes I could have 3 or 4, but that means the acuity or how sick the patient is required a lot more of my time. For med surg units, which was rare that I got sent to, or like a PCU, a progressive care unit, it could be anywhere from 5 to 6. But in some facilities in the state that I'm in, they take up to 8 or more patients on these med surg units, because the idea is that they don't require as much interventions from the nurse, which, depending on, like you said, it's kind of a free-for-all. It's kind of a dumping ground.
Oh my gosh, it is. You could have a post-op patient roll in, have a psych patient that you need to tie down in another room. You can have another person with a blood sugar of 700. I mean, their med surg is the busiest floor. I think, yeah, ICU is one thing, but you're very regimented and contained in an ICU, right? Most of the time, your patients are intubated, so you have controlled
chaos.
Yeah, it's controlled chaos. Yeah, but on a med surg floor, I mean, anything goes. Then you have, and then you have the doc that's coming in and discharging the patient at 4 p.m. And so you got to get that patient out because charge nurse just called you and said, we have an admit coming in. You got to get that patient out so we can clean the room, so we can get that patient in. Meanwhile, you're taking post-op vitals. I mean, you hear where I'm going, listeners? Like, there's a lot going on. So even if you had a couple of patients that required a lot of time, even that 1-4 ratio is a lot. That 1-6 ratio, the only reason they do a higher ratio at night shift is because typically, hopefully, patients are sleeping, right? So you could do it. Now,
they've never heard of sundowners, those people, have they?
Oh my gosh, sundowners.
They're like hanging from the rafters at night shift. They're so sweet during the day, and then they're hanging from the rafters at night. But just to piggyback on what you said about SACE and ratios, I'll tell you this interesting story. I was 6 months post grad, new nurse, brand new nurse, right? 6 months. I get floated for the very first time off my unit. Now I was in CVICU at the time. I did not start in I started in the CVICU and then I went to ICU. I've never worked med surg other than being floated.
Okay, so
So they
that's cardiac ICU.
Yes, sorry,
Yeah.
cardiac ICU. So they went ahead and they floated me down to med surg, which is all well and good. They gave me a ratio 8 patients. Eight
No.
patients. Okay, yeah, yes, 8 patients. One of them had a blood pressure of 79, like over 30 or something ridiculous, with no IV access.
Mhm.
Uh-huh. Yeah.
All of these patients needed to be, and I'm like fighting I'm trying to refuse this assignment. I was like, this is not safe. I'm a brand new nurse. I was like, are you people high? I'm not used to these ratios. Like, I mean, it was, everything about it was not safe.
Yeah.
So, I would implore nurses, when you know that you're in an unsafe situation, I don't care if you're a month out, 6 months out, 10 years out, if it's not safe, do not accept the assignment, period. They are forced to make it work. They are
Yes.
forced to call in another nurse, or God forbid, they are forced to take a patient themselves.
Yeah.
Those nurse managers, get on the floor, managers, get on the floor.
Yeah. Yeah. No, I
Sorry, I'm gonna
agree
go on
with
a
you. I mean, so
tangent.
that's very important and for people to understand, these ratios, they're more and they're pushing it more because so many of us left the bedside.
Right.
Right. And I mean, and there's a big part of me. There's a big part of me that you know how I always tell you guys that, I have like the devil inside my head trying not to, he's trying to use my mouth, right? But
Oh,
I really, I really try to silence him and put him in a little corner because there is a big part of me that's like, dude, what did you think was going to happen? What
Exactly.
did you think was going to happen
exactly.
when we said we are leaving because we don't want to participate in an experiment? And then the nurses did not step up. So there's a huge part of me that's just like, hey, you get what you asked for.
Yeah.
You get what you ask for. But then there's the other part of me that loves people and I love nursing and I love all of the principles that I stand for, right? Like the three of us, we stand for those 9 principles of nursing ethics. They forgot a bunch of them. And now they're wanting to come back and say, hey, we're not doing this anymore. But, for us to say, like, too bad, so sad, that's not in our character. So now we're like, okay, well, how can we help? Like, what advice can we give you? And I guess it would be striking. I mean, what else are they going to do? They have to strike. They have to put their voices out there and say, this is dangerous. But you know what is just shocking is when I look at the thread, let me see if I can pull that up because I look at the thread and what these people are saying, and it's like, oh my gosh. Okay, well, we have to go to break. So we'll go to break. And then when we come back, I want to play you a little clip of the news media or the news station in Hawaii that is talking about this and telling you what some people are saying. Well, what a vast majority of people are saying, what the public feels about nurses today versus what the public felt about nurses in 2020. But before we do, I want to direct you guys to check out ASEA. ASEA is a redox signaling molecule that helps at the cellular level. People ask all the time, well, what is that? Well, guys, we take supplements, right, to provide nutrients for our cells. But if our cells aren't functioning at an optimal level, then those nutrients will not be absorbed as efficiently as they possibly can be. And that's where the ASEA Redox cell signaling supplement, it's 2 ounces in the morning, 2 ounces in the evening. It's basically salt water with this redox technology that nobody on the market has, as far as I know, that helps to boost your cell at that cellular level to uptake these vitamins and nutrients and to give you energy. I know Nurse Kimberly talked talks about her experiencing revitalizing energy. The same with me. I just absolutely love this product. So I encourage you to go to americaoutloud.shop and get our exclusive discount, only available to America Out Loud Talk Radio listeners. And we'll be right back. Welcome back. You are listening to Nurses Out Loud on our Tuesday edition Q&A. And I have with me Nurse Kimberly, your Wednesday host, and our special guest nurse co-host, Nurse Nicole. We are opining on several of your questions, and we will continue that. I want to play this clip from Hawaii News Report, and this is concerning the nurses' strike in Hawaii right now.
Young children hospitalized with health challenges have been unable to sleep because of the striking nurses outside Kapiolani Medical Center.
After 2 days on the picket lines, we're also seeing how those nurses are treating their temporary replacements. Our Eddie Dowd reports from Bingham Street.
Well, these nurses have been here on strike since Sunday. More than 600 union workers walking off the job without pay. Now, we're already starting to hear complaints from within the hospital about noise, but union reps tell me they can't stop cars from driving by and honking in support. Dozens of nurses at a time have been chanting and line dancing, purposely making their voices heard to raise awareness of their complaints about the staffing at Kapiolani Medical Center.
We don't want to be there every day for 16 hours.
Horns, a lot of horns. That really is the one that stands out the most.
Marissa McElfresh's 3-year-old son is battling a rare genetic condition. She says she had to move rooms because the noise was keeping her son from resting.
Because he was constantly being startled, it was really hard for him to get a good amount of rest. That was my main thing. It was causing me a lot of anxiety.
We've got our patient and family liaisons that are rounding on our patients, and they're giving them little earphones for their ears and little mufflers.
We've also heard complaints from patients across the street at Shriners Hospital.
I want to say sorry. You know, it happens with a strike.
The nurses union is leading the week-long strike, hoping to reduce the number of patients assigned to a single nurse to avoid burnout and improve the quality of care. They say the last thing they wanted to do is disrupt patients.
I would complain to the management, employer, and just say, hey, let's get it done. It's bothering us. You know, go with the nurses. Let's meet back at the table and let's get this done.
On Monday night, the striking nurses blocked the bus taking their temporary replacements back to their hotels in Waikiki. The police allowed them to delay the transport for 3 minutes. Back inside the hospital, despite having to move to a quieter room, McElfresh says she still stands with the nurses and their fight to improve staffing conditions.
I support them, and I hope that everything works out for them. You know, I do hope that things get better for them.
Eddie Dowd, Hawaii News Now.
First, it's young children.
So there's that. I mean, she said something in there that I think people don't realize, and we even haven't touched on this. She said, I don't want to work 16-hour days anymore, because that's what happens, right? If you don't have the staff to be able to show up to accept your assignment, you cannot leave.
Nope.
You guys want to talk about that?
Yeah, I mean, I've actually had to work a couple of 16-hour shifts because for that very reason, because we were short-staffed and we had to wait for somebody till day shifts could get somebody in there. And yeah, you can't leave because it's that's patient abandonment and your license is in jeopardy at that point. So it's not as simple as saying, well, you know, screw this, I'm out. You know, you can't do that. And that's the same reason when I say don't accept an assignment that is not safe, because you're jeopardizing your license, right? And if you think that the hospital is going to have your back, it's not. It's not going to have your back. They will be the first ones to throw you under the bus every single time. And that's why I do recommend, because a lot of nurses won't get their own liability insurance. They are under that false hope or idea that the hospital's insurance will cover them. And well, that's true in theory. The hospital is going to throw you right under the bus. You need to have your own protection in place. I think we've seen that demonstrated over and over, and Redonda Vaught's a good example of that.
Yeah, and it's only a couple $100 for the year.
Yeah, it's not a lot.
Yeah.
It's absolutely not a lot. But yeah, that clip made me kind of sad, you know, because again, it's like the definition of insanity where we're doing the same thing over and over again. We're expecting different results. And that's why I don't partake in these nursing strikes, because it doesn't change anything. And at the end of the day, we're supposed to be caring for patients. It's supposed to be about patient care, patient safety. So the idea that, you know, we're making patients uncomfortable, I just don't like it.
So what can they do then, Kimberly?
I mean, you can come work for Remnant Nursing. I can tell you that. I'm just, you know, listen, I know everybody can't leave the bedside. I get that. But here's what has to happen. I think that a number of us walking away and starting something completely different, right? The more we become viable, right? And an option for people. The problem now is that people don't have any other alternative. In many cases, the standard of care is being met in these hospitals. It's just that the standard of care is so disgustingly low in this country. It's not that it's not being met, it's that it's so low, and it's disgusting. And I think we can all three speak to that. But there's no other alternative for people. Right. So as long as we are coming out here and we're creating something and people understand that they don't have to go to these hospitals, they can come to these other alternative organizations and other facilities, they're not going to have any choice but to raise their standards in order to remain viable and relevant. So I think that's one thing that we can do. I think that's what we're doing at Remnant Nursing. And again, I've been saying from the beginning, I wish we could burn the system to the ground, but the fact is that's not going to happen. And there's always going to be patients that no matter how hard they try, will not be able to come out of that system. So we've got to do the best that we can on this side to ensure that they're raising their standards on the inside. And that we have good nurses like Nicole, who's still at the bedside fighting for those patients every day, that they have informed consent. Because if you think about it, she's probably one of very, very few nurses that are not just kind of going along to get along. She's in there, but she's speaking up and she's educating those patients. Mm-hmm. So we're going to need more Nicoles in that system. So I by no means myself telling everybody to walk away and leave, but we have to do something, and it has to be something drastic.
Nicole?
That way we're going to get different results.
I think too, like, depending on the state that you live in, you know, I always try to kind of give a different kind of point of view. You need to know the laws in your state. You need to know what you're protected by and from, if you will. If you work as a healthcare worker, you need to know what's going on in your hospital system. You need to make sure that you know up front, like, what the expectations are, the types of acuity and the ratios that they are telling you versus what ends up happening do not always coincide. But, you know, kind of going back to what Kimberly said, you know, I worked on a unit one time that we were, you know, it's like a step down unit, and we were supposed to have 4-to-1, and sometimes we come in, it'd be a 5-to-1, and we didn't have enough resources, and we had new nurses titrating neosynephrine, which is a medication for blood pressure. Really shouldn't have been on the type of floor that we were working on, and the acuity was so high. And so we kind of banded together some days that we came in and we didn't clock in, and we made a very big deal about not being okay with taking the 5-to-1 ratio. And that was met with a lot of resistance. I had one time the CNO come down and say, you know, you're going to take it because you can't leave these night shift nurses here any longer. They've already worked. And, you know, really just kind of explaining the unsafe situation. So, you know, to kind of go back into it, it's like, you need to know that if you're going to work in the hospital system, it's high risk, high liability, it's very broken, and there's a lot of things you're not going to be able to necessarily change. However, not accepting an assignment, don't clock in. I just want to say that if you clock in and then you don't accept it, it's considered patient abandonment, especially in Florida. But
thank you for saying that, Nicole, because I did forget to mention that about the clocking in.
Yeah, a lot of people don't know. They just assume. Yeah. So don't clock in, always check your assignment, make sure things are looking okay. You know, if you have time to go ahead of time and try to see what kind of patients you're getting, you know, it's not going to be perfect always. You just need to be able to speak up. One of the things that I do on the side is, you know, starting up like legal nursing and as a consultant and just kind of seeing what we're seeing that these hospitals are doing and how they're putting these healthcare workers at risk and they're allowing these bad behaviors and bad practices to happen. So as nurses, it's your responsibility to be able to identify what you can handle. If you're being floated somewhere, do you have the experience in that specialty to work safely and within your scope of practice? You know, don't accept assignments that are not safe. You know, you have to be reasonable because again, there's certain things that just kind of blow up and people are just not wanting to do certain things, not just because they don't want to. You have to have, we're professionals, we have licenses. You have to make sure you use good judgment and your critical thinking. Patients rely on us when we come into work to have someone take over. Your coworkers rely on you to relieve them so they can go home because legally we cannot leave. So it's really knowing your laws, you know, what are you capable of, making sure you don't clock in, look at your assignments, see if this is something, you know, you're comfortable with, and then always document, whether that's in the chart that you let someone know you're not comfortable with an assignment. That could be debatable. I say do it, you know, or letting your management know via email with your name on it and their name on it. Always notify through the chain of command that this is not okay. You don't feel comfortable. You don't feel safe. Print that out. Make sure you have it so that you're protected so that they can't say you did not notify someone, because most of the time that these nurses are taking these assignments and something bad happens, you can't use the staffing. It's not something that they're going to let you pursue in court from that aspect because you knew about it and you still took the assignment. So it's just really being aware of what your rights are as a particular floor nurse. So, you know, again, it's not going to be easy, but always be able to document or speak up for yourself because you could potentially save lives. You know, again, you could get injured, you could make a mistake. And like Kimberly said, they will throw you so far under the bus. And when we talk about the liability, just really quickly, you are only covered by the hospital if you follow policy and procedure and standards of protocol to a T. Now, I can tell you when we're put in some really bad situations, I'm not always able to do that because sometimes we have to MacGyver certain things and work within a system to protect us and the patient. If that ever was found out, they could use that because it's not technically policy and procedure. Whereas someone that goes and gets additional insurance, one of the biggest complaints that nurses make is, I don't want to be double sued. Well, okay, the hospital's not going to cover you anyways. So you want to have your own protection so that if something happens, you can have representation to unbiasedly represent you, because the hospital is only going to look out for themselves. HR, risk management are not for you ever. They are for them. So I say that working in a hospital system, you know, again, it's what they have to do. It's a business. It's a working machine to keep them going. They don't care about anything else except the bottom line. So just know that they need you as much as we need to take care of our patients, but you have to be safe. You have to be smart. So always just know what your rights are and to make sure that you're very keen to that, because there will be situations that you could be put in that you could be considered guilty for because you took the assignment or you agreed to it or you didn't follow policy and procedure or the standard of you know, reaching up to the chain of command. If we don't do those things and you can't prove it, then, you know, we're just as at fault. So you just want to really educate yourself on that process.
So I have a question with regards to accepting assignment, because many times you don't know the charge nurse is coming in at the same time you're coming in, right? And the charge nurse is getting report from the offgoing charge nurse, and then they make up the assignment. So the clocking in part, I mean, I think for me, and I don't know, like Nurse Nicole said, look at it legally, but I mean, when you walk into work, you punch in your time clock and then you hang out there until they do shift report, right? And then you're coming in and doing shift report, and then you're finding out what your assignment is. But until you get that patient assignment and you hear report, that's not your patient. It's not your patient. So if I'm coming in and I find out that, hey, there's only 2 nurses here with me in the break room, and there's usually 4 or 5, at that point, I'm saying something, right? And I know I agree with you, Nicole, is people need to document in the chart. If you have a patient that you're taking care of and you didn't get to them, and you were delayed, in giving their meds or putting in their vitals or whatever it is, put a note in there, that you're working short staffed and, patients on monitor, you're visually seeing it and monitoring, but you weren't able to document something like that. And then I remember one of my teachers, she told me, she said, I had a little notebook. I had a little notebook that I kept with me.
I had one too.
Yep. And she said, and anytime there was something that just felt a little off, or something had happened on the shift, she said, I would put their initials and the date, and I would write a little note, because that will hold up in court. That will hold up in court, because you could say, hey, listen, on this date, I took a note. This was what was going on. I think that's probably one of the single best things that we can do is to keep that little notebook of that. So that in case we are ever called into question. But yeah, like if you are the nurse that's coming in 15 minutes early every day, and you're hovering around, breathing down your charge's neck, saying, what's my assignment? What's my assignment? I mean, they're just going to target you.
Yeah, but the assignment should be is typically made on day shift by the charge nurse on day shift. That's how it was in my hospital. The day charge would already make the assignment. So it is kind of like it just depends. But I think it's kind of a difficult thing, because here I've tried that a couple of times where I didn't clock in and I would go and hang out first, and then I would always forget to clock in. So that's always not a good strategy for me, because it's me. So.
But it isn't a bad idea. I think it's a great idea she had. Try to make it a point to get to work 10, 15 minutes early. Don't clock in. Check out what the vibe is on the unit. You know what I'm saying? And understand what you're walking into before you clock in. I think that's a great idea. You don't have to walk around saying, don't give me that patient. You know what I'm saying?
Right.
But that is a good idea. Plus, it helps you to relax a little bit, go to the bathroom before you start your shift. So that's a good practice to have. Then we only have like a few more minutes left. I did receive another email from Jessica, who says, thank you all for speaking out and for having this platform on Nurses Out Loud. What advice would you give me to speak to my nurses on my floor? I've always wanted to use my voice, but I've always been silent my whole life.
So I think, to me, I like to, I like to ask just thought-provoking questions. I don't like to throw just throw all these facts at them, and because you lose people, you have to learn to meet people where they are.
Right.
And you have to remember that there were times when many of us were not really awake or aware to what was going on either. I was part of the problem just 4 years ago, encouraging vaccines everywhere, get your flu shot, get all of that. So that you have to remember there was a time when we weren't awake and aware either. So learn how to meet people where they are, and just ask thought-provoking questions. My favorite one is like, if all of the people were dying of COVID, then why weren't we pulling bodies from homes and off of the streets? Why is it the only place anyone is dying is at the hospital? And when I asked that question, just in a nice, calm way, not in an accusatory way or anything like that, just in a nice, calm way, people stop and they think, and they're like, yeah, gee, I never really thought about that, but you're right. And that plants a seed, and it usually grows from there. And when you don't attack people, and like I like to say, if somebody's thirsty, give them a sip of water, don't turn on the fire hose, because again, you're going to lose people. So I think just kind of meeting people where they are, ask thought-provoking questions, and just be willing to have that normal civil discourse and discussion with people, and understand they may not be where you're at, but you got to plant the seeds where you can. That's my best advice. That's all I got.
So is this question more directed towards related to the COVID stuff, or just in general of being someone that is trying to make an impact with the nurses that they're with?
It sounded general. They're just thankful that we are using our voices, and they want to be able to do the same.
I think one of the biggest things that I did when I worked with management or like as a charge, you know, it was always like lead by example. I know that actions go a lot further than words. I mean, we've all worked in jobs where, you know, people that you're supposed to look up to are supposed to be like in management, people that are supposed to know what's going on. Don't always lead by example. You know, that's easy to kind of tell somebody what to do. But, you know, like Kim said, like when you're short, you get on the floor, you know, you do things to help and, you know, be that person that they can go to. So one of the biggest things that I used my voice for was, you know, we're all having silent struggles that a lot of people don't realize are going on. And when people came to work, it was such a chaotic environment and we were always short staffed and there's, you know, there's all these things that are going on. And just to really like know your people, you know, if you're somebody that's a charge or a manager, like really get to know your people, you know, make it genuine, try to build those relationships where you see how they're doing, like genuinely doing, and also lead by example. You know, if you're short staffed or if you can help answer a call late or, you know, I just, like I said, actions really speak volumes and it really sets the tone for a collaborative team to come together and know that that person has my back. And we don't really see that anymore in healthcare. And that's one of the biggest things that like really kind of broke me from the beginning was anybody that I've worked with will tell you like I gave 110% and I stood up with them and for them and you could ask me anything. I was always there. You could call me on my day off. Like I was just that, I've just always been that nurse. The patients come first and foremost, but also the safety of my staff. And so to make that impact, sometimes if you're uncomfortable having those conversations about anything in general, it's just like show your actions, just show that you care, show that they matter, that you value them as a coworker or an employee, and that, you know, you follow through with things that you're going to say and that you just genuinely listen. We don't have much empathy and nurturing anymore in this field. It's very kind of short and jaded, and you know, we have newer generations coming in that just kind of vibe different. And so if it's not their job, they're not going to do it kind of deal, which doesn't really resonate with me because we're all there to do the same kind of job. But, you know, again, lead by example, you know the expectation and work together. And like Kim said, like meet them where they are. You know, there were a lot of nurses I worked with that may not have been the best at bedside, but they were great people and could have, you know, had left and gone to do different things that they were really good at. And that's okay too. You know, it's okay to not necessarily be a bedside nurse. So again, just meeting them where they are with how we work as a team and how we communicate with people, how we, you know, work together to resolve conflict, you know, really just being that point person that people can trust and go, yeah, okay, this is, because we always talk about why do people really leave? You know, a lot of jobs, they say like what, 80% of it is because of who your leadership is.
Yeah.
You know,
they don't leave the job, they leave the management.
Exactly. So a lot of times if you're in those positions where you can have an impact on your nurses and just see them for who they are and know that this is, if I was a new nurse coming into this field, I would be absolutely terrified. This is a whole shenanigans of events. So, you know, I can't fathom what they're going through. And like you said, Miss Jodi, like they just don't know what they don't know. And a lot of times experienced people or individuals that have been there for a little bit, like you see these things and we don't know how to talk to each other. We don't want to be offensive. You know, everybody's walking on eggshells all the time because we can't say anything to anybody without being offensive. This is healthcare. We're dealing with people's lives. So sometimes we have to figure this out. You know, we have to work together as a team and put our big girl boy pants on and just know, you know, that I can trust who is my leader, who is my point person, and they're not going to belittle me, talk bad about me, be toxic, and put me in environments that are not safe. And so that's one of the things that I strive for and why I've stayed, because to me, it's like my identity is just going and making the people that are giving this type of care feel empowered to want to stay. Like this is not a job for everybody. Not everybody can do this. And some may not want to, and that's okay. But the people that stay and are able to really put their all into it, the impact that you can have is it's just amazing. And so we lack that a lot now. So I really hope for her, for the person who gave the question, you know, just be empowered to nurture your team, you know, really be there.
And that those are great. I think I'll close it out by saying this briefly. Speak with love, speak from the heart. always, don't give in to gossip. Don't, somebody wants to vent to you, let them for a short time. But don't go down that path. I think the enemy tries to use our tongue, because it doesn't have one. So it comes in us to try to speak through us. So don't go down that rabbit hole, don't go down that path, because it'll only just, torment your soul in the long run. And then also speak with science. Like, we have evidence-based science. Evidence-based practice is what we are supposed to use all of our interventions, and what we do is supposed to be based on that. So if you are using evidence-based practice, not the newest thing that the CDC comes out with or FDA, you're actually using evidence-based practice, speak your mind, because that's what the three of us did. We knew, say, masks didn't work, period, done. Show me something different. They don't have anything different. So it's those types of things. But that's all the time we have for today, friends. Thank you so much for joining us. Remember, we are on air 5 days a week on your favorite podcast platform by typing in nurses space out space loud. It's 3 separate words. As always, we would love to hear from you. So go to nurses@americaoutloud.com. And until next time, be safe, be well, and God bless.